Hello, my name is Yuko Kono from UC San Diego. I'm going to talk about ultrasound and CEUS LIRADS today. HCC is diagnosed mainly by imaging without biopsy, unlike other cancers. All the major societies endorse imaging diagnosis when criteria are met. Therefore, it is critical to have strict and accurate criteria to avoid misdiagnosis. Major imaging criteria includes arterial phase hyperenhancement or AFI and washout. However, there was no standardization or good guidance how to diagnose ACC in the past. What is the definition of those imaging features? What do you do when it does not meet these criteria? In the past, ASLD and EASL recommended biopsy for all non-ACC nodules, but are they all the same? And it was difficult to do validation or comparison when there was no standardization. LI-RADS, Liver Imaging Reporting and Data System, is a system for standardization. It standardizes terminology, technique, interpretation, reporting, and data collection. It consists of algorithm, atlas, lexicon, and index. So in 2006, radiologists from UCSD and Thomas Jefferson gathered and created an initial version of LI-RADS, modeled after BI-RADS, which is for breast imaging, of course. It was then endorsed by ACR. The first version of CT-MRI LI-RADS was published in 2011. In 2017, ultrasound and CEUS LIRADS were created and added to ACR LI-RADS. And in 2018, AASLD guideline included or endorsed LI-RADS for HCC diagnosis. However, they only endorsed CT and MRI and did not include CEUS LI-RADS. We currently have 4 different algorithms, including ultrasound surveillance algorithm, CEUS diagnostic algorithm, CT-MRI diagnostic algorithm, and CT-MRI local regional response algorithm. Currently, CEUS local regional response algorithm, CT-MRI radiation therapy response algorithm, and CT-MRI systemic therapy response algorithm are in development. So let's review ultrasound LI-RADS. Ultrasound is recommended for HCC screening and surveillance for high-risk patients. And so US LI-RADS is pretty straightforward. The purpose is to standardize the report. US1 is negative, so there is no suspicious lesion. US2 is subthreshold. There is a small, less than 1 centimeter lesion that is not a definite benign, like cyst. And ultrasound 3 is a positive ultrasound with nodule or observation greater than 10 millimeter, or new thrombosine vein that triggers diagnostic study. Now, you may have noticed that we use those familiar wording, observation, in LI-RADS documents. And this is really, it came from CT-MRI, where they have pretty frequently non-nodule observations. Basically, they have perfusion abnormalities or pseudo lesions that may not be nodules. So we start with observations, but in ultrasound, which really we have nodule-based imaging. So we see nodule; it is a nodule most of the time. So you can start using nodule, but we start with observation. As the same as CT MRI. So I may kind of interchangeably use observation and nodules. Now, It is very important to assign ultrasound visualization score. A is with no or minimum limitations, B is with moderate limitations, and C is with severe limitations. It helps interpreting the results. I usually consider switching modality when visualization score is C. Now, when there is US3 positive ultrasound, then you want to move to diagnosis using CEUS or CT MRI. So we will review CEUS LIRADS next. There are currently 8 CEUS LIRADS categories. So we go from top to bottom. LIRADS NC or non-categorizable is basically image quality is poor, or like no atrial phase or contrast phase as something happened, and you really cannot assign any categories. And we try to avoid this, but sometimes it happens. And then we have LIRADS 1, which is definitely benign, which is like hemangiomas or cysts. And as number goes up, the relative probability of malignancy will go up. LIRADS 5 is a definite HCC, so you can send a patient to treatment without biopsy. On the other hand, LIRADS M is probably or definitely malignant, but not necessarily HCC. It includes intrahepatic cholangiocarcinoma, metastasis, and some HCCs. Now, many people misunderstand LIRADS M equal cholangiocarcinoma, and HCC should not be included in LIRADS M. The specificity of LIRADS M is not very important because we have to biopsy cholangial or metastasis in any way. So even if you are really, really sure if it's cholangial, we're gonna do biopsy, right? And remember, LIRADS 5 is not gonna be biopsied. So we want to include any of those lesions into LIRADS M rather than including LIRADS 5. So LIRADS M is really important to keep the specificity of LIRADS 5. So LIRADS M will be biopsied. Now, this graph is showing the probability of HCC and malignancy. The data is from CT and MRI, as we have more data on CT and MRI. Y-axis is the probability of HCC, x-axis is probability of malignancy. And as you can see, it's really nicely lined up from LIRADS 1 to LIRADS 5. And LIRADS 5 is 94% HCC and 97% malignant. And LIRADS M is 36% HCC and 93% malignant. So how does this help? Why we're doing this, right? Because this will help stratifying the management. So LIRADS M will be treated as an HCC. LIRADS 4, on the other hand, it is likely HCC. A lot of HCC actually fall into this category, but it's not definite. We cannot say 100%. So depending on the situation, it can be biopsied. It may be treated as an HCC or maybe observed. So we usually discuss at multidisciplinary discussion. LIRADS M will be biopsied, as we discussed. LIRADS 1 or 2, on the other hand, it's not likely an HCC or malignant. So we can go back to surveillance. So it helps stratifying the management. There are 4 steps in LIRADS diagnosis. Step 1 is to apply decision tree and table. You will apply ancillary features next, which is optional. You will then apply tie-breaking rules if needed. This happens actually really rarely in my experience. I never actually used it. And then step 4 is a final check. You need to really check, does this make sense? And so that's how we use it. Here's how diagnostic tree and table looks like for CEUS LIRADS. Currently, CEUS LIRADS algorithm is only for blood pool agents such as Sonabute, Lumason, or Definity. Sonazoid is not included in current algorithm. So you will go from top to bottom. First, exclude non-categorizable, and then tumor in vein, LIRADS 1, LIRADS 2. I do not have time to explain each category in details today. The next is LIRADS M. So what is LIRADS M criteria? It is any one of those three criteria: RIM AFI, or early washout, or marked washout, which I'm gonna review in a few minutes. If any of these categories are met, then the nodule will be categorized as LIRADS M. And the rest, we will apply this table. So let's go to the table. You will have LIRADS 3 and 4 and 5. And how to use this table is we need to look at three important components: how big, nodule size, the presence or absence of AFI, and note this AFI is not RIM or not peripheral discontinuous globular because LIRADS M is already excluded, and LIRADS 1 or hemangioma is already excluded. So these are other AFIs, and which I will show you in a few minutes. And then you need to look at the washout. There's no washout or late and mild washout. Now remember, early washout or marked washout is already excluded. Those are LIRADS M, right? So at this point, we have either no washout or mild, late and mild washout. And I'm not going to talk about ancillary features in details. Fortunately, there are only a few ancillary features in CEUS, not like CT MRI, which is listed here. And it's basically to adjust categories, upgrade one or downgrade one. For example, if there's a lesion that is categorized as CEUS LIRADS 3, but you see a growth in the nodule, it's bigger, definitely bigger than last year, then it will go up to LIRADS 4. Please remember, LIRADS 4 cannot be upgraded to LIRADS 5 using ancillary features. To meet to categorize as CEUS LIRADS 5, it has to meet these stringent criteria for LIRADS 5. Let's review some of the important imaging features. These are non-hepatocellular type AFI. Here are some examples of RIM AFI, which is major features for LIRADS M. So these are LIRADS M. Now, these are peripheral discontinuous globular AFI, which is major features for hemangioma. So these are going to be LIRADS 1. Other AFIs, hepatocellular type, like these are AFI in whole. The entire nodule is enhanced nicely, homogeneously, or AFI in part. It can be a little heterogeneous, especially when it's a little bigger. Mosaic pattern is a typical HCC enhancement pattern, especially seen in the larger HCCs. And then nodule in nodule. These are the HCCs developing in dysplastic nodules. So these are hepatocellular type AFI, and these nodules will be categorized into LIRADS 3 or 4 or 5, depending on the size and the presence of washout. Let's review washout. So in CEUS, it is very important to evaluate the onset of washout after injection and the degree of washout, not like CT and MRI where you only look at the presence of washout. So if the washout starts early, in less than 60 seconds after injection, it is called early washout. And if it happens after 1 minute, it's late washout. If the washout is really marked, which is like a block or punched out by 2 minutes, it's called marked washout, and others are mild washout. So if either early washout or marked washout, these will be LIRADS M, and only late and mild washout will be LIRADS 3 or 4 or 5, again, depending on the size and the presence of AFib. So let's review how it looks like, these washout. So these are early washout in less than 1 minute. So these are LIRADS M. These are marked washout, black before 2 minutes, that's CEUS LIRADS M. And then late and mild washout, these are 4 or 5 minutes. These are late and mild washout. That's LIRADS 3 and 4 and 5 again, depending on the size of the nodule and the presence of AFib. Now, I get asked sometimes, when these washout can become marked, right? That's this, like these washout happens like 2 minutes, and then by 5 minutes, if you keep watching, it can become black like this. Is that marked washout? No, this marked washout happens before 2 minutes. So it is very important to do the right imaging protocol for CEUS liver imaging. And it's basically, you need to do a real-time imaging. Of course, it's low MR imaging to evaluate arterial phase. And I usually stop imaging after peak enhancement. You can continue to watch up to 60 seconds if you would like. But then after that, you want to do intermittent imaging. If you continuously observe throughout the phases, what happens is you destroy bubbles, even with low MI imaging. And by 3 minutes, 4 minutes, bubbles are gone, and you cannot assess washout by 5 minutes or 6 minutes or 7 minutes. And typical HCC wash out really late. And I had HCCs wash out like 6 or 7 or even 8 minutes. So you want to preserve the bubbles. Don't destroy bubbles. So it's really important to minimize ultrasound exposure. And so that's why we do intermittent imaging. So let's review the case. This is a 63-year-old female with alcoholic cirrhosis. There's a nodule, 2.5 centimeter, and you can see a nice, homogeneous hyperenhancement in arterial phase. And then at 2 minutes, there's no washout. It's homogeneous. It's ISO enhancing at 2 minutes. And then at 3 minutes, 5 minutes, you see the washout. So how do we apply this table, right? So there is AFI, it's greater than 10 millimeter, and there is a late and mild washout. So this is a CEUS LIRADS 5 definite HCC. How about this lesion? This is a 64-year-old female with hepatitis C cirrhosis. She has a 3.1 centimeter hypoechoic lesion, and that shows arterial phase hyperenhancement. This nodule washes out like 30 seconds, right? It's already getting darker. So this is CEUS LIRADS M with early washout. So the patient underwent biopsy, and it was actually a lymphoma. So how accurate is CEUS LIRADS? This is the largest retrospective validation study was published by Dr. Piscaria's group with over 1,000 nodules. And they reported the specificity of LIRADS 5 for HCC was 98.5%. So it's very accurate. And I'm just reporting this because this is the most important thing in CEU, the LIRADS, the specificity of LIRADS 5. And of course, other, things like what's the probability of LIRADS 4, 3, or 2, 1, or sensitivities. These are important, but not as important as the specificity of LIRADS 5 for HCC. Now, recently published meta-analysis showed LIRADS 5 specificity of HCC to be 88%, however, so it was lower than we would like. Currently, we are conducting a multi-center prospective validation study for CEUS LIRADS. So it consists of 11 international centers, and we are aiming to enroll 640 patients and compare CEUS to CT MRI and pathology. This is NIH funded. PI is Dr. Lechik from Thomas Jefferson. So these are the participating sites. University of Bologna, Dr. Piscaria's site is the leading enrollment, and I think they were kept very early because they enrolled 100 patients very quickly. And UCSD, my site, is also participating as well as other sites. So this is the interim analysis that was presented at RSNA last year. With 575 nodules from 530 patients, and the specificity of CEUS LIRADS 5 for HCC was 97.2%. So that was very encouraging. To summarize, ladies and gentlemen, HCC can be diagnosed by imaging without biopsy. Therefore, accurate imaging criteria is critical. LI-RADS is a system to standardize technique, terminology, interpretation, and reporting for liver imaging in patients at risk for HCC. CEUS LIRADS is used for HCC screening and surveillance reporting, and CEUS LIRADS is developed for HCC diagnosis with a CEUS. CEUS LIRADS 5 is a definite HCC, so you can proceed to treatment. CEUS LIRADS M is a malignant, but not specific to HCC, so you need to do a biopsy. You need to evaluate arterial phase enhancement in a real time and washout in the intermittent imaging. And washout is very important to assess timing and degree. So the future direction for CEUS LIRADS is, so we would like to finish multi-center validation study and really would like CEUS to be included in a major society guidelines for HCC diagnosis, as like ASD and EASL. And CEUS LIRADS manual is in process. Hopefully we can finish soon. And we are starting new projects, including CEUS LIRADS local regional treatment algorithm and CEUS LIRADS with Sonazoid. Here are the resources. You can visit ACR website or simply Google CEUS LIRADS, ACR, and you can download CEUS LIRADS core and essential slides and manual to be released hopefully very soon. You can also send me an email with any question. And I also wanted to let you know that CEUS LIRADS is now translated into 8 languages, thanks to the contributors. I'm not listing them here, but you can see the translation credit in the ACR website. And these are also all free to download. So it's all in different languages if you like. And then lastly, this is our current CEUS LIRADS working group members. And I would like to thank you for your attention. Thank you so much.